A 98-year-old Caucasian woman, body mass index BMI of 17.2, with a known medical history of hypertension, rate-controlled atrial fibrillation, hypothyroidism, aortic insufficiency, lymphedema, and hypoxia secondary to partial lung resection on home medication of warfarin, levothyroxine, metoprolol, montelukast, furosemide, ipratropium bromide, and fluticasone, presented to North Shore LIJ Plainview's Emergency Department at 2:30 p.m. after a witnessed fall not associated with head trauma or loss of consciousness. Her vital signs on presentation were blood pressure of 144/81, pulse of 119 beats per minute, respiratory rate of 18 breaths per minute, temperature of 98 degrees Fahrenheit, and oxygen saturation of 85% on room air. Our patient's baseline oxygen saturation was unknown, and she denied being on home oxygen therapy. On physical examination, our patient was not wheezing on presentation, but revealed shortness of breath on room air with diffusely scattered rhonchi. An electrocardiogram, ECG, revealed atrial fibrillation at 113 beats per minute, along with right bundle branch and left anterior vesicular block. At 3:30 a.m., our patient suddenly became bradycardic and progressed to asystole. She was found to be pale and pulseless. Cardiopulmonary resuscitation, CPR, was immediately begun following an advanced cardiac life support, ACLS protocol. Initial respiratory support with a bag mask was attained, and our patient's trachea was secured with incubation at 3:32 a.m. As per the ACL protocol, 1 milligram of intravenous epinephrine was given, followed by 40 milligrams of intravenous vasopressin given at 3:36 a.m. Our patient finally received her second dose of 1 milligram of epinephrine at 3:40 a.m. Finally, at 3:46 a.m., our patient received 1 ampoule of sodium bicarbonate. Our patient remained unresponsive to continued resuscitation efforts, so CPR was abandoned at 3:48 a.m. Right femoral venous access had been attempted during the resuscitative effort, and cardiac monitors were unwittingly left on our patient during cleaning and removal. At 3:51, before the complete removal of femoral venous catheter, a single ventricular contraction was noticed on the monitor. This single contraction progressed to a couplet, and then a triplet, and finally into a normal sinus rhythm with palpable pulse at 3:53 a.m. Her initial blood pressure was measured at 80/50, and our patient was started on norepinephrine drip at 10 micrograms a minute through a femoral venous access. A right femoral atrial line was also established for continuous blood pressure monitoring. Her blood pressure stabilized at a mean arterial pressure of 70, and our patient was transferred to our intensive care unit, ICU, at 4:30 a.m. In ICU, a hypothermic protocol was initiated, and vasopressor were titrated to maintain systolic blood pressure greater than 90. Unfortunately, at 10:55 a.m., our patient went into ventricular tachycardia, and despite resuscitative efforts, our patient was pronounced dead at 11:03 a.m. Prognosis: Lazarous Phenomenon.